Thank you very much. Zoya, what I understand is that this diagnostic journey can be very long, right? And sometimes painful for families. So maybe there are way to go faster, and today we have more and more pilots about newborn screening. Um, Jackie, you have first-hand experience in such pilot. Are you happy to share with us your experience?
It's very tricky when you're implementing a newborn screening program. It's very different from when you are diagnosing a child later because the family are sitting in front of you with a perfectly healthy newborn infant, as opposed to a child that has been picked up by other healthcare professionals or by daycare or kindergarten or whoever with an actual clinical sign. So it's very, very tricky. And one of the first tests, as you said, we can do is looking at the CK levels. But unfortunately, it can be a little bit hard to determine if this baby has a high CK because they have Duchenne muscular dystrophy, or maybe it was a traumatic birth just on their first day of life, because anyone can have one elevated CK. If anyone went and did a CrossFit class or ran a marathon, their CK the following day would be elevated. And if you think of, birth can be quite traumatic for some babies. And so you need to be really careful about how you interpret a CK on a baby that's only a couple of days old. So also there are other forms of muscular dystrophy that a child can have an elevated CK. So traditionally here in Australia, when newborn screening was set up, it was a biochemical screening test. So the children would have a blood spot taken, and that would be run in the laboratory, and they would be looking for biochemical markers. But as we said, CKY, while it's an excellent marker for Duchenne, it's not completely diagnostic. So we have started screening in Australia some other conditions on our newborn screen, looking at the actual genetics and the molecular diagnosis. And unfortunately, it's a lot cheaper than it used to be, but it's not the cheapest test. It's a lot more expensive than doing a biochemical test. So we've integrated into a larger genomic program. However, as we've said before, there are 70% of pathogenic variants in the dystrophin gene that lead to Duchenne are duplications and deletions, and only about 30% are actual sequence variants. So that makes it a little bit more tricky than a condition such as SMA, for example. So we are about to start a pilot program in Australia. What we're going to do is look at the molecular basis of the babies for Duchenne, and we have to do looking at the copy numbers and at the sequencing as well.
So, Jackie, could genomic be a first-tier test if we have a genomic newborn screening program and CK a second-tier test to be sure that the variants that are identified are pathogenic?
That's what we're planning on doing. So watch this space because hopefully that is our theory, and hopefully that's going to work very well. So yeah, we're about to start very soon. And so, yes, if we have this conversation again in about 6 months to a year, maybe I'll be able to be a little bit more definitive. But yes, that's exactly what we're planning to do.
And that's what we are doing in Southern Belgium also.
So there are many different pilot studies going on around the world where we're looking at exactly this. So here's just a few here, one in Taiwan, they're looking in Europe as well and in Belgium. So there's quite a few going on. So hopefully this will become part of the mainstream for newborn screening in the future. But in Australia, as I said, we're about to start a pilot study. So what we want to do is diagnose early, because the earlier that you diagnose, the better chance you have for early intervention and surveillance. The other advantage of having early detection is for reproductive planning in the future for these families. It can be very tricky though, again, because Duchenne is an X-linked recessive condition. So you need to be very careful, because with mothers, in the time frame that you are doing newborn screening, they are at an increased risk of postnatal depression. So one of the things that we are a little bit concerned about is causing more grief to a family, and especially to a mother, because if they feel like this is their fault and they're being blamed for this, it can not have great outcomes for families. So we are going to be very careful with that, and we're going to hopefully have a lot of support from social work and psychology to hope that we can support our families through this. So also early detection. If we do identify that there are females in the family who are carriers, the other benefit of this is to implement a surveillance program for themselves, because, as I'm sure you're all aware, females who are carriers are at risk of developing cardiomyopathies. So one of the things we're hoping to achieve is to have some early identifying female carriers and putting in some preventative health strategies for them. So we're hoping to start in the next 12 months, and yeah, we will see how it goes. So we're very much looking forward to it. And as you can see from the diagram here, this is how we're hoping to do it. So if we start with looking at the CK, and if it is a normal CK, then no further screening tests. And then if it is elevated, then we're going to go from there. So looking, if they do not identify any pathogenic variants in the dystrophin gene, then we won't be screening any further. But if they have been identified, then the newborn screening lab in New South Wales will flag the result to the paediatrician and the neuromuscular specialist. The way that in New South Wales, how newborn screening results are given is usually by the paediatrician at the hospital where the child has born. But we have trialled it for SMA, and we're going to trial it for Duchenne, that it actually works better if the result is notified by the neuromuscular clinic and the neuromuscular specialist. So then the infant and the family come to see us at the hospital, and we try and do this within 24 hours because, you know, as soon as you make that phone call, they start Googling. And as you said, Zoya, they can see some pretty horrific things when they Google. And so we try and see them as quickly as we possibly can. Okay, so when we then see them in the hospital, the plan is to repeat the CK and to repeat the test that was done on the newborn screening lab, but also to collect some diagnostic bloods so that we can confirm in a NATA accredited lab. Because it's always important to remember that this is a screening test, it's not an actual diagnostic test. So that's also a very important factor to bear in mind.
So thank you very much, Jackie. And thank you, Zoya. I think that it's good to have a diagnostic, better early than late. But then we need to think about treatment, right? And that's the next step.